let me check recording. Okay. Good afternoon and welcome to this second week of the Political Science 216 course on the 2020 Presidential Election Public Lecture Series. My name is Joel Cassiola, and I am a member of the Political Science Department, and I am delighted to welcome you to this very important and unique topic. This is the fifth time this course has been offered on presidential elections. And in a way, it's sad that we have to have a topic on the pandemic virus. But I thought when creating the subject matter for this course that it didn't seem proper to have a course while the virus is raging through our society and already cost the lives of 180,000 people, to ignore this dominant activity and development in our society. So here we are with, I think, the strength of the San Francisco State faculty really made visible. We have 4 experts on public health who will talk about different aspects of the virus. And I hope that you, along with me, will learn a lot about the nature of the virus, the nature of our response, and perhaps about the future. So let me begin. Before I do that, the strength of this panel, which you will see soon, is owed to 2 members of the faculty that I would like to personally thank. Professor Marty Martinson, chair of the newly named Public Health Department, really worked with me to put this panel together. And my former colleague, Dean Amy Sueyoshi of the College of Ethnic Studies, also assisted me greatly in helping to put the panel together. So I want to thank both Amy and Marty for their assistance in making this panel possible. Now turning to our first speaker, Dr. Emma Sanchez-Vaznor is a social epidemiologist and professor in the Department of Public Health in the College of Health and Social Sciences at SF State. She serves as an affiliated faculty member at the Center for Health Equity at the University of California, San Francisco, and the Health Equity Institute at SFSU. Dr. Sanchez-Vaznor research focuses on social inequalities in health and childhood obesity. She received her doctorate in social epidemiology from Harvard University. Please welcome Emma Sanchez-Vaznor.
Thank you, Dr. Cassiola. I'm very happy to be here today. And I'm going to share my screen so I can get started. Let's see. Okay, I hope everybody can see that. So I look forward to an interactive discussion. There are a lot of things that we can say about COVID-19. My presentation today will focus on the epidemiology of COVID-19, specifically focusing on social factors. So first, I will briefly review some background about COVID-19, and then I will provide a summary about its natural history, which is basically the progression of the disease in humans over time. And then I'll talk about who is affected and where COVID is more prevalent, and some of the possible reasons about its unequal distribution across people and places. So COVID-19, just to be clear, is a disease that is caused by the virus called severe acute respiratory syndrome, or SARS coronavirus 2. As we all know, the virus spreads very easily from person to person through close contact, especially if that contact is prolonged and if you are in crowds, indoors, and or in places that have poor ventilation. The way in which the disease progresses over time is very important. And in my field, which is epidemiology, we call this process the natural history of the disease, which begins once a person is infected with a virus. As you can see from this visual, in stage 1, the body begins to respond to the virus through the onset of symptoms. However, with COVID-19, there is a wide range of possibilities. For example, people can have 0 symptoms and have the virus, and the disease will never progress to stage 2 or stage 3, while others can have symptoms like a sore throat or cough or fever and progress to stage 2 or 3 or recover in either one of those stages. In stage 3, the virus starts to replicate and to affect the body in various ways. Initially, the lungs were affected in many patients, but we now know that other parts of the body can be affected as well. For example, some people have had strokes and they thought that it was a stroke, but actually it was an indication that they were infected with a virus. In stage 3, the consequences can become more severe, and they can include pneumonia, respiratory failure, acute respiratory distress syndrome, and so on, all the way to death. So let's just put some numbers to the COVID story. As of yesterday, the World Health Organization calculated that there were about 25 million cases of COVID-19 in the world, with about 844,000 deaths. In the United States, we have about 6 million cases and about 181,000 deaths. This is probably most likely an undercount, and I'll talk a little bit about that later. So data is critically important because we are talking about life and death, literally. So we need to know who is affected, where, why are some people more affected than others. And answering these questions can help us to reduce the spread of the disease, as well as how to treat it or prevent it. Initially, we did not know the answer to many of these questions. But more recently, we are starting to get more information about this. So emerging data is now showing that there is a disproportionate impact across the population in terms of social factors, which is what we call in epidemiology. And these social factors include age, race, ethnicity, as well as medical conditions that were existing before the pandemic, and the places as well as the characteristics of those places. This is a very busy slide. The data comes from the Centers for Disease Control, and it shows hospitalizations and mortality data due to COVID-19. I just want us to focus on the red rectangle and the yellow arrows. As you can see that as age increases, the risk of hospitalization and death also increases, with the worst hospitalization rates being, among those who are 75 and older. Although, okay, so this is a slide that shows hospitalization rates and their disproportionate impact among African American, American Indian, and Latinos. As you can see from the left side of the panel, those groups have significantly higher hospitalization rates compared with the with white population. Here we also see that Asian or Pacific Islander populations have slightly higher rates of hospitalization, but this is national data, and oftentimes national data can mask the disproportionate impact among Asian Americans. So for example, in California and some of the counties here in this table, if you just see take a look at the yellow highlighted cells, we can see that although Asian Americans make up 12% of the positive cases in San Francisco, they account for almost 50% of the deaths. The other thing to note is that there are persistent racial and ethnic disparities in hospitalization rates within every age group. And so as you can see in this slide, that non-white groups for all age groups have higher rates of hospitalization. So on the left-hand side, we see the age groups 0 to 17, 18 to 49 years old, and then the rate of hospitalization. And so anything that you see above 1 means that that group is more likely to be hospitalized due to COVID. So for American Indians, you see that the rates are much higher than 1. For non-Hispanic Blacks, the same thing, as well as for Latinos and Asians. But the worst disparities are between African American and Latino populations. So what this tells us is that the disparities persist even after you take into account the differences in age in these populations. So moving on to underlying conditions, the risk of hospitalization increases if people have at least one underlying condition. But it increases even more if people have 2 or 3 or more conditions. And for some conditions like chronic kidney disease and severe obesity, the risk increases even more. And this is especially concerning since we have an obesity epidemic right now going on in the United States, as can be seen in this graph. So in the United States, as of 2017 and 18, about half of the adults who were 20 years or older were either obese or severely obese. COVID-19 cases are also distributed unequally across levels of geography, whether you can think of it in terms of county level or state, and even across countries. So as can be seen in this data by county, the darker red signals counties that are experiencing more cases. And this slide shows deaths by counties in the United States. So the situation is similar in terms of disparities across counties. And the CDC provides data by state, and they provide those as a percentage of the population. and you can still see differences between states as well. We also know that COVID-19 is patterned based on the characteristics of places. So for example, as shown in this graph, the infection rate is twice as high in the poorest zip codes compared with the most affluent zip codes, as can be seen on the left-hand side of the graph. Similarly, we see patterns by race ethnicity. So infection rates increase with increasing proportions of minorities. So for example, the infection rate here is 5 times higher in majority minority zip codes than in zip codes where the non-white population is less than 10%. This is another example of what I was talking about in the previous slide. And then in terms of countries, we see the differences across countries. And I don't have a picture for you, but the Johns Hopkins University has a very nice resource of information where you can compare different countries and their curves. So one important question that that is revealed in this data is, why is it that we see these racial and ethnic disparities in the impact of COVID-19? And so one of the prevalent explanations is that we have long-standing root causes that we call inequalities created by the societal structures rather than by individuals that basically have sorted out Latinos and African Americans, for example, into the types of employment that they hold. These groups tend to be less likely to be able to work from home during shelter-in-place orders. And so African Americans are more likely to be, and Latinos are more likely to be frontline workers. For example, they hold occupations in grocery stores and food packing companies or in delivery. And so these occupations tend to have a higher and prolonged exposure to people who might have COVID-19, even if they don't have any symptoms. There's also some data that many of these employment places have different practices and to protect employees. For example, differences in protective equipment, as well as testing and tracing and quarantining their employees. Okay, so the employment characteristics that I was just talking about also have some kind of intersection with housing characteristics. And so this also adds to the risk of exposure to COVID-19 and its impact. For example, Latinos tend to live in larger households. And if they were infected at work and come home, then the spread of the disease could be even higher for those households. And then there are very widely documented inequalities in health. These populations tend to be more likely to be diagnosed with diseases that are related to COVID-19, such as diabetes, heart disease, and lung disease. There's also less access to quality health care for these populations. So that increases the risks that are already there. In epidemiology, we call these place effects to things that are, to attributes that have to do with places, not people. And so, as I mentioned before, we see variations in the impact of COVID across counties, zip codes, and states. And so one of the explanations for this is that there's a difference in the policies that are being implemented, as well as the changes in those policies over time. As you can see here, we see the effects of the shelter-in-place policy in the pattern of COVID-19 cases in San Francisco. And also compliance with the policies that is very likely to vary across place. And then finally, that the politicization of COVID-19. Okay, I'm almost done here, and I just want to talk about a couple of challenges. There are at least 3, but I'm sure many more. The first is how to protect the health and life of the population, as well as the health of the economy. And so there's a very major question that we see in the media and in the research world about how to strike a balance between the two, and whether that is even possible given what we need to do in order to contain the virus and the spread. We also have many knowledge gaps. There is some good data coming out, but we are refining the data as it comes. And the rates that we see, for example, for the death rate, we know that it's probably most likely an undercount. The New York Times just did an analysis where they found more deaths than we would expect. So the conclusion is that deaths due to 19 are undercounted. And then finally, of course, there is hope. And as you all probably know, there are a number of efforts in clinical trials and so on that are trying to find both effective treatments as well as vaccine. And I'm going to end there.
Okay.
Thank you.
Thank you very much, Emma. It was very clear to see the interesting data, which we may have seen in part through the media, but it's great to have it all together in one presentation. So I appreciate that very much. Our second speaker this afternoon is Professor Laura Mamo, who is Professor of Public Health at San Francisco State. Dr. Mamo received her PhD in medical sociology from the University of California at San Francisco. She is a sociologist of science, technology, and medicine, whose research examines the gendered and sexual dimensions of medical technology and practice, and its intersection with the social and cultural dimensions of health and health equity. She is interested in issues of justice in science, medicine, and healthcare, and most recently was awarded a National Science Foundation grant to study the equity politics of cervical cancer prevention technologies. Thank you, and I should have said thank you to Emma for her presentation. And now I want to introduce Dr. Mamo and thank her for her appearing on this panel.
Thank you. Thank you, Joel. Thank you, Dr. Casiola. Thank you, Emma. I put my slide up a little bit early, so I apologize for that, but I hope you all can see the slides. I am going to take a slightly different approach because, as Dr. Cassiola mentioned, I study the cultural and social aspects of health and illness as a public health scholar. So I'm going to share with you some of the things I've been thinking about in this brew, if you will, of COVID-19, of presidential politics, and of the movements for Black lives. So I've been thinking a lot about the politics of knowledge, about truth and truths, about trust and trustworthiness, and about the ways knowledge can be manipulated for certain purposes. That is, the ways knowledge can be politicized. Knowledge for social scientists and for many of us is always understood as situated. It depends on who you are and where you sit, and it is contingent. It changes based on our context. But knowledge has become a domain of contention in particularly unique ways in the past few years. Experts and expertise are often viewed with suspicion. I've especially been thinking about George Floyd's murder and the concept of gaslighting. There was an article written by a group of physicians and published in the Journal of Scientific American called Structural Gaslighting. In this article, the physicians spoke of George Floyd's autopsy, the first of 3 autopsies. On May 29th, an autopsy report was released, and the country was told that in this autopsy report, it was revealed that George Floyd had there were no physical findings that support a diagnosis of traumatic asphyxiation. No physical findings that support trauma caused his death, the report said. It went on to say what was found was potential intoxicants and a pre-existing cardiovascular disease that likely, in quotes, likely contributed to his death. This was then later found to be misinformation, and it was not benign misinformation. What the report did was misattribute the real social cause of death. The police violence and trauma was attributed instead to a biological cause, something about George Floyd's body and health. In the next few days, 2 independent examinations would invalidate this autopsy. And by extension, these 2 independent examinations would invalidate the role of this autopsy in undermining the police officers and policing as what is really to blame in Floyd's murder. So these physicians, a collective group of physicians, a group of experts, were writing to refuse the expertise of the first autopsy report and to call out the structures of medical expertise that allowed this report to come to be. And I quote them, "We will not be complicit in the ongoing manipulation of medical expertise to erase government-sanctioned violence." So what happened here started me thinking. For days, Black Americans sat and still sit with the all too familiar pain of being told that the truth is not true, of fearing that the law would believe an expert report over the reality that they saw, that we saw with our own eyes, and that many have lived with their own lives. As the authors wrote, it's a miscarriage of justice that deepens the cut. Not only can Black people be killed with impunity, a physician's autopsy report can be twisted to replace the truth that we all saw. So we were all gaslighted here. We were told that what we saw, that what we knew to be true was not true. So this is a difficult story, but it's an important one, and it's part of the stew that I think we've all been in these past times. It informs what is happening and has been happening, and it also helps us to think about the presidential election. There is a lot of structural gaslighting going on. And so what is gaslighting? Gaslighting, by definition, is the attribution of cause or blame for something to something else. So to attribute cause to something that it is not. To make people question what they know, what they saw with their own eyes. And to make people think they're crazy. And I don't know about you, but I've been feeling pretty crazy lately. Gaslighting can be political. It is political. It's purposeful. Of course, truth does exist and facts do matter. And data matters, as our colleague just pointed out. And one truth that exists is that in the US, 180,000 people have died due to a virus. This is not their fault, nor the fault of their biologies or pre-existing conditions, as we learned in the last slide. It is quite complex and due to multiple factors. But when we are told it is our fault for being old or poor or Black, we are being gaslighted in a particular way. We are being structurally gaslighted, as the physicians in the American Scientist let us know. And we wonder, what can we trust and what is trustworthy information? And it made me think about this again at the Democratic Convention, which many of you may have watched, when Kristen Urquiza spoke of her father's death from COVID-19, an active young man, an adult in mid to late age, who had died recently. And when Urquiza gave her powerful speech, she stated his only pre-existing condition was trusting the president. In other words, her father was gaslighted too, when he was told that wearing a mask would not prevent the disease, or perhaps that he was not at risk, or perhaps that it was a hoax, or perhaps it would go away, or something else. But he was not told the truth. So in public health, when attribution of death is blamed on something else, we refer to this as missing or misattributing the root causes of disease. And we heard this in the last talk as well, a mention of the real root causes of disease. What we know as public health professionals is that the root causes are driven by the social and structural determinants of health. And in public health, there has been powerful and pervasive knowledge showing this truth. The truth that in fact health and disease is driven not solely by biology, but is driven by the social and structural ways in which we organize social life. I share this table with you. It is a usual table of the root causes of disease, with each column attributing what we know to cause both good and poor health. This is not new information. We have always known this information, and it has been measured, validated, and reproduced over time. The more money one has, the more education, the more equality they are given, the more rights they are granted, the less discrimination, The less violence and the less denial of one's humanity, the more health they have. The longer they live, the better they live. So when we were gaslighted by George Floyd's first autopsy, the claims made by experts in power were made to deny this truth and instead to blame the possibility that he may have had an underlying condition, taking our eyes away and misattributing the real cause of George Floyd's murder. And I know that's a lot. And I take us back to COVID-19 again, and to San Francisco data that also was shared in the prior presentation. We know in San Francisco that the cases, just the positive cases of COVID-19 are 51% and most prevalent in Latinx communities. Not because of their bodies, but because of the ways our social life is organized, because of our occupations, because of the work we do, because of where we live and the homes we live in. So even when we have the truth and we know the facts, and we know, like Professor Emma Sanchez showed us, that the impact of COVID-19 is disproportionate, this deluge of data documenting inequality in disease and death is not new. The continual documentation can be helpful. We need data, we need truth, we need facts. But as one of my friends and colleagues, Ruha Benjamin, says, the facts alone will not save us. And even when we know the loss, as many of you might know firsthand, we still question the cause, the attribution. We're still left wondering. Why are we left wondering? What is happening? So what does this have to do with the presidential election? There's a lot of gaslighting going on. There's a rise of conspiracy and other falsehoods. There's a co-optation of social movements for health, rights, and justice. And as I said earlier when I began, that experts and expertise are questioned in a different way. Some of it is needed and necessary, and I don't think we need to go back to a time where we accept the truth of experts without questioning that. What we need to do is some questioning. And I share this image with you, and perhaps you've seen it yourself. It's an image we see at many pro-Trump rallies. And in some ways, this image is making me feel crazy. It may be making you feel crazy. Here are people co-opting a social movement for health and rights to reproductive care into a lie that mask wearing is an affront on individual liberty instead of a proven and known and well-documented public health approach to prevent disease and save lives. So returning to the truth, the facts alone, even when we have them, these facts may not save us. We must see through this misinformation and we must participate. So when it comes to the presidential election, there may be two choices, but the real choice is how to participate in knowledge production and circulation without romanticizing a time when we were differential to the truth of professional experts, nor allowing oneself to be part of a mobilization of falsehood. How do we fight expertise with expertise? And we have examples of fighting expertise with expertise. I won't read each one, but in our history, we can stand on the shoulders of giants. The Black Panther Party fought for food justice with expertise. The women's health movement created knowledge of our bodies to fight the misinformation and lack of knowledge of women's bodies. And AIDS activists challenged discrimination and stigma by using science, by becoming scientists, so that they could fight to move and fast-track drugs that were needed to the market. And there are social movements now, and this is a way of participating. I give a few examples of social organizations and movements that are being called forward to fight expertise with expertise. So as I end, I will return to the two choices of presidential politics and ask you to think about your participation. You, the public, we, the people, get to decide who and what counts in society. What is truth and what is trustworthy, and who will govern us going forward. The current administration and conservative followers, I believe, support gaslighting, obfuscation, confusion, misattribution, and misinformation, particularly of the cause and means of preventing COVID-19. They deny science, expertise, social movements, democracy, and participation. These are the facts. The coronavirus in the US has 181,000 deaths. These deaths are preventable deaths with good information, with the right knowledge. These could have been prevented. So we must remember that a virus may have infected the body, but that our exposure to that virus has a social cause, a root cause, and it is the structures of society. When we speak of government, we are speaking of how our government intervenes in and shapes the structures of society that make us vulnerable and protect us from health and illness. I know you'll be covering the policies of both candidates in this semester. I provide a few from the Biden-Harris campaign because they are offering a plan to prevent, treat, and end the pandemic. They are offering a plan to support and expand public health and public health care. They are offering a plan to support families. I provide a few other examples of how they're going to do so in terms of supporting families with better pay, with relieving debt, supporting families with health care policies for health. They're looking at climate change. They're looking at the green economy. They're expanding community health centers and Medicaid coverage. And they're investing in public education. These are part of their platform. So I had to end a little partisan, sorry, but the way forward toward knowledge, toward health, equity. Thank you very much.
Thank you very much, Laura, for that very interesting and certainly incisive presentation. We will now move to our third speaker, Professor Grace J. Yu, who is a professor and former chair of the Asian American Studies Department. She is currently the first-year experienced faculty director. Professor Yu has a master's degree in public health from Loma Linda University and a PhD in sociology from the University of California at San Francisco. For 2 decades, she has led research projects focused on social support and health among women of color, immigrant communities, and Asian Americans. During the pandemic, Professor Yu has been a volunteer with the Pacifica Beach Coalition and Anti-Sewing Squad. Professor Yu, the floor is yours.
Thank you so much, Joel, and thank you to all of our presenters today. I want to say my talk is a bit different. It's a bit about my own journey during shelter in place, my own way of coping, and my own response to the pandemic. At the beginning of shelter in place, I must say, for all of us, we were experiencing panic and shortages of all kinds. Toilet paper across the United States. In my community, it was milk. A common sight to be seen that we saw were families over preparing, maybe even hoarding. And at the same time, our government had created massive confusion about facial coverings early in this pandemic. So early in this pandemic, I knew I couldn't really rely on what was occurring in the United States. I couldn't really find the necessary information I needed to protect myself here in the United States. I realized I needed to look elsewhere, and I started to Zoom with my cousins in South Korea, where they had seen a containment in cases and a decrease in COVID cases overall. So I was starting to Zoom with my cousin in Korea. And my cousin in Korea said the key to their society functioning at that time, you know, folks were going to restaurants, they were going to movie theaters. She said the key were masks. Wearing masks was key to South Korea functioning. But here in the United States, I was receiving so much confusion from my president. This is an April 3rd White House briefing from my president. He states, with a mask, it's going to be really a voluntary thing. You can do it. You don't have to do it. I'm choosing not to do it, but some people may want to do it, and that's okay. As I greet presidents, prime ministers, dictators, kings, queens, I don't see it for myself. I just don't. And then later we see in a July 12th briefing, a different take. He states, we're asking everybody that when you're not able to socially distance, wear a mask, get a mask. Whether you like the mask or not, they have an impact. They'll have an effect, and we need everything we can get. I will use it gladly. Anything that potentially can help is a good thing. So fascinating. This is so interesting. From April 3rd, we have the statement from our president, and then on July 12th, we have a different kind of statement. And so this, I believe, had created so much confusion. There was also confusion from the CDC. This is the US Surgeon General on February 29th, and his Twitter, he tweets, they are not effective in preventing the general public from catching coronavirus. But if a healthcare provider can't get them to care for such sick patients, it puts them and our communities at risk. And so, again, the early onset of CDC stating and confusing people about not recommending the use of face masks. And so I'm just giving you a timeline here. This is a timeline of here in the United States. On February 26, 2020, the Centers for Disease Control raises concerns about COVID-19, about community spread after a woman in Solano County becomes diagnosed despite no prior travel history. And then on February 27th, 2020, Vice President Pence states that the spread of coronavirus is low. And then February 28th, we have our president call the coronavirus a Democrat's new hoax. This is February 28th. And then on February 27th in 2020, CDC issues a statement about not recommending the use of face masks to help prevent COVID-19. And then, of course, the US Surgeon General tweets, surgery people stop buying masks. This is February 29th, 2020. And then we see on April 3rd, 2020, the CDC reverses its earlier recommendations on masks and now recommends the use of face coverings when around others. And later we start to see various cities also having various mask mandates. We see on April 8th, 2020 in Los Angeles, the mayor orders employees and customers of various establishments to start wearing masks. I want to talk about mask mandates across the world. You know, I really started to look outside the United States in terms of, you know, what people were doing. And in Taiwan, you know, they had masks available as early as February 6th, but they ordered a nationwide mask rationing system. So only folks could get like 2 masks per week. And they mandated masks April 1st for public transportation In South Korea, mask wearing was highly encouraged as early as January 20th, 2020. And then April 13, it was compulsory when leaving the house. In fact, you were fined if you didn't. And in the Philippines, they started to require masks as well as on April 2nd. I'm sorry, let me go to my next slide. As well in Spain, early April, mask mandate was also part of, was also compulsory. Now I have this picture, this was taken on April 28th, 2020. And this is Vice President Mike Pence, who is visiting COVID-19 survivors. And I just, I think the picture says it all. Our leadership at that moment in time was not wearing a mask. And this is April 28th, 2020. And those around him obviously are wearing a mask, but he is not wearing a mask. Now we see in terms of Republican and Democrats, this is a study by the Pew Research Center. We do see some differences, but we also see, increasing use of wearing masks from June 2020 to August 2020. We see that there's an increase among Republicans. We've seen that increase, and then Democrats, obviously, there's a larger percentage of folks wearing masks, and so there's definitely differences between Republicans and Democrats in terms of mask usage. And obviously, I think everyone saw this picture of the Republican National Convention, and again, the picture speaks for itself. You could probably look at all the folks in this picture, and you see, like a sea of people, but maybe one or two people wearing a mask. So, which is again, and really kind of close together, not necessarily socially distancing. But again, this picture kind of says it all. At the same time, we've also seen anti-mask protests throughout the United States. And this one just occurred like last week in Costa Mesa. And we've been seeing this throughout the United States, various anti-mask protests. And the theme throughout these protests is defending one's personal freedoms. This is like the common theme in terms of these anti-mask protests. Now, I'm going to introduce you to this term of craft activism. And I want to say that I'm a craft activist. 10 days into the shelter in place, I decided I'd attempt shopping for the very first time. And I wore a mask at the store, and I entered the store, and half of the shoppers were wearing a mask. However, the folks that were working at the cash register had no mask. And at that time, there were no glass there was no covering. They were literally at the cash register without a mask, helping all the various customers come through the store. And I had asked the manager if they could get masks, but he had said they could not get masks. It was so difficult to get a mask in mid to late March. On social media, I was also horrified. I had former students that were healthcare workers that were petrified going to work because there was no PPE, and they were kind of freaking out on social media, and I was really, really concerned about them. No one was protecting them. And so this was about spring break. Spring break, I think, is third week of March for us this last year. And I then made it my goal to start sewing. I've never sewed before in my life. I don't have a sewing machine, but the wonders of social media, by simply announcing on social media that I wanted to sew and I needed a sewing machine. I literally within 24 hours had someone that was willing to teach me to sew, which was my colleague, Valerie So, her name's So, Professor Valerie So, who taught me how to sew over Zoom. And my other colleague, Professor Kira Donald, who just gave me her sewing machine to sew and also a bed sheet to sew with. And so I started sewing literally the week of spring break, and I made my first 10 masks with a bed sheet and the elastic around the bed sheet. Because the other crazy thing during this time period, it was really difficult to find elastic and fabric. I literally, at Amazon, it said elastic would arrive in May and fabric would arrive in May. And so, again, the wonders of Facebook, I kind of like reached out to my friends and I said, I want to continue making masks for grocery store workers and healthcare workers, but I don't have any elastic. You know, elastic is like the new toilet paper. Can anyone help me out? And so again, the wonders of social media, my cousin in South Korea mails me like literally elastic and fabric and gets me started. And later I also joined a group called the Anti-Sewing Squad, who also is able to supply me fabric and elastic. And elastic, let me tell you, between March and April, elastic was gold. It was so hard to find elastic. I literally was breaking it from my clothes, older pieces of dresses, shirts. I was just taking it and using it to make masks. So anyways, my sewing adventure began during spring break. I was sewing for healthcare workers without PPE, healthcare workers who didn't have PPE, farm workers, low-income elderly living in assisted living facilities, low-income elderly that lived in nursing homes, and uni bus drivers. It turned out to be my way of coping. And everyone has different ways. This is myself. I was making masks for grocery store workers in my neighborhood. And these are kind of my first masks. They didn't have masks and I started making them and distributing them. And again, I think all of us have been coping during the pandemic in various different ways. And unfortunately for me, I cannot watch Netflix. I tend to over-identify with fictitious characters and it's not really good for me. And so sewing became my way of coping. And it continually serves to be my coping resource during this time period. So as a faculty member, I was also starting to think about limited opportunities in the summer for students. And I was starting to think my grand vision was to get students sewing this summer because I knew there were limited opportunities. And so this summer, I got a crew of folks sewing with me. By the way, these are the masks we've made. We've made over 1,000 masks. And it's part of our craft activism that we've done. And we've relied on donations of people donating or letting us borrow sewing machines. Also, like I've mentioned, my cousin sending initially elastic and fabric from South Korea, but then people like throughout my network also giving me everything they had in their closets as they were cleaning. You know, they had thread they were finding cloth. And so our initial masks were made with donations and then sewing machines that were provided by family and friends. And later we all joined the Anti-Sewing Squad. These are my students that were sewing. And again, between all of us, we sewed 1,000 masks. Again, these are some of our masks. And they were sent to San Quentin, farm workers, and various low-income communities throughout the United States. Now, I want to I'm going to end here, but I want to just kind of encourage all of you if there are ways for you to engage. And I want to let you know there are several different initiatives here at SF State. One is actually a group of, Aspire is leading a group on coping with COVID-19. If you've been impacted by COVID-19 personally, or you have a family member that's been impacted and you would like other students just to kind of support you through this, Aspire is leading a student group on this. So I encourage you, this is a bit.ly on this, to take this information. I will share it with your professor as well, so he can also kind of remind you that this exists. And this will start September 22nd. They're just meeting 1 hour every week for 6 weeks on Zoom. So this could be a great support for you, especially if you've been impacted by COVID-19. The other thing I want to make mention, it's never too late to sew a face covering because we still are in the pandemic. And now we have the fires. And I'm leading a group of students in terms of sewing every Thursday night, 7 to 8. And we're going to start next Thursday again. So if you'd like to join, this is the information. It's a great group of students. In fact, some of the students want to start a sewing club here at State. But it's a great group of students to learn sewing from, and also to socialize, because I know during this time period that it's really hard for a lot of students to interact with one another. And so this is such a great space. We're going to be sewing and socializing. So I encourage you to join. Again, I'll send this information to your professor. Thank you.
Thank you very much, Professor Yu. Professor Yu has to leave quickly, so I will look for a couple of questions. If you have a question for Professor Yu, we can use this time. One question, Dr. Yu, why not a face shield? Better being wider, as a question.
Well, I think folks are using a face shield, but the mask, because it's closer to your face, offers better protection. The face shield, if you're right here, right, there's still kind of dispersion of sort of air droplets that could still occur. So the face mask, because it's covered, is actually more efficacious. By the way, there are several scientific studies on the efficaciousness of face masks. And so versus like shields, and they've shown that facial masks are actually much more efficacious. So
another question is, why are you emphasizing the mask but not hand gloves?
Why am I emphasizing the mask and not hand gloves? Well, mask is because that is sort of where the spread is. It's through sort of droplets, right? When we speak, right? It's like this, all the air that comes out, that's where the transmission is. Gloves, you know, that's where the hand washing comes in. And so, I mean, folks may still use gloves. I know at the very beginning I was using gloves, but now I've really resorted to hand washing. Yeah.
Okay, one more question. Why not recommend washing the face too, which is the main entry of the virus?
Sure, but I would still say wear a mask. Wear a mask,
Okay.
and after you're out, wash your face.
All right,
I
so
think
you
wearing
should,
a mask is just crucial at this point, you know?
right, you should do both.
Yes, you do both. Like,
Okay, all right. Thank you very much, Professor Yu. We really appreciate your photos of the masks were quite beautiful. In addition to being functional, the aesthetic value was really surprising. The variability of the materials, and they really show the kind of contributions you got of material, so that the masks are very attractive in addition to being functional.
well, that's fantastic. If anyone needs a mask, you don't have access, you are always welcome. I will mail you one. You could put your
Great.
email in the chat,
Okay.
and then I will get back to you all. But we have, you know, 9 SF State students that were selling this summer, and so we made
Terrific.
1,000 masks, and so we're still
And
selling
those-
this fall.
And those students deserve to be commended as well. And
Oh.
so please pass along the thanks of everyone who's viewing this video. I hope I can speak for them in congratulating the students for making that great effort as a group and making a contribution to society in a really important way.
Yeah, I know it made a difference for them.
Great.
But if
Okay.
anyone wants to learn to sew, next Thursday, 7 o'clock.
All right. Thank you.
Sure.
And-
Bye.
All right, so long, Grace. And now for our fourth and final speaker, Professor David Rebinal, who is Assistant Professor of Public Health in the College of Health and Social Sciences. Dr. Rebinal conducts epidemiological research and mixed methods evaluations with a focus on informing interventions that can address the social and political determinants of racial health inequities. His current research examines the roles of neighborhood features, immigrant political participation, and neighborhood social capital on the mental health of Asian Americans. Dr. Rebinal has nearly 2 decades of public health experience, including working at the U.S. Centers for Disease Control and Prevention in Atlanta, Georgia. He holds a Doctor of Public Health degree with a focus on social epidemiology and community development from UC Berkeley School of Health. Dr. Rebenal.
Thank you, Dr. Casciola, for inviting me to be here with you all, and thanks to all of you on the call listening in. If anyone's listening in on this call who works on the front lines, I just wanted to first say thank you for your service and your valuable response. You know, if you're an essential worker, et cetera, you know, all those working to respond to this pandemic, risking your lives to make our communities healthier should be commended. And so I just wanted to wrap up, I think, some really thoughtful presentations and talk about what's next. So I entitled this presentation, Pandemics, Public Health, and the Presidential Election 2020, Moving Forward Towards Health and Equity. And so, you know, today, September 1st, you heard the epidemiology from Emma, and, you know, we really are at an inflection point here on this pandemic, and really in this country, right, with this coming election. We're 63 days away from the election. Today marks around month 6 or so, or approaching month 6 from our stay-at-home orders here in California. Now we have some welcome news that you know, rates of infections and deaths may be plateauing, but they're certainly still relatively high. And a reminder that it only took us 1 month from a case count of 5 million on August 9th to now 6 million today. And so we're going to be dealing with this for quite some time. And so this crisis really has reminded us how unprepared the world is to detect and respond to emerging infectious diseases. And so what I hope to talk about is what we can do about it, what investments we can make now that can help us navigate and prepare, both from making, you know, from, you know, what make things worse, but also for future pandemics. The other thing that we know, and we've heard clearly from the other speakers, is that this pandemic has exposed and has worsened profound inequities in our U.S. healthcare and public health systems that trickle down in our communities. And so that we know that communities of color and low-income populations are at greater risk of the infection and mortality, and also the social consequences of these disparities. And so what I wanted to do was just give an overview of some public health recommendations moving forward and discuss those in consideration for the 2 candidates. And so I'll focus really on the presidential candidates because of the series focus. And before I get into some of those recommendations, I want to take an opportunity to situate this public health conversation with two sort of definitional things, 2 contextual things. One is what is public health? And I think we've been using public health assuming everyone understands what it is. And so the Institute of Medicine really defines it as what we as a society do collectively to assure the conditions in which, and I add the word, all people can be healthy or achieve optimal health. And so the public health endeavor is is made up of government, private industry, community members, community organizations, other sectors, right? And so this sort of web of sectors and organizations sort of depicts that, and we have graduates from our program that work in all these sectors. But I really want to concentrate my remarks on our public health system, our public health agencies, of which, who is responsible for assuring the health and safety and wellness of all people in its jurisdictions, and at the federal level, all people who live in this country, and not just paying customers, not just subscribers. right? And so public health is what we do as a society to collectively do that. And the public health agency sort of sets guidelines and policies and enforces them at the federal level, which gets down to the local levels. The other aspect is that public health has indeed been preparing for this pandemic. And I didn't have to go very far back, but I just wanted to take a stab and just show and remind folks. And certainly when I worked at the CDC, in 2002 to 2006, much of the focus of my training in field epidemiology was in disaster preparedness and bioterrorism preparedness, because it had just been after 9/11. And so we saw in the second Bush administration, lots of emphasis on preparing for pandemics and preparedness. We see in Obama responding to the Ebola outbreak. There was avian flu, SARS, all kinds of Zika virus not too long ago. And so, right, we have editorials, we have briefings to say that it's not if, but when. But yet here we are, right? And so I say those two pieces to keep in mind as I sort of go through what I and some other public health experts are recommending whoever wins this next election take on. And as participants in this process, I hope you would consider some of these recommendations as you choose which candidates' values and policies they put forth. So the first recommendation I wanted to do is really to come back to scientific leadership, and that is to restore the authority that the CDC had. So we have an infrastructure that can deal with this, that has dealt with similar crises. Certainly not at the scale anytime recently, but there are experts, right? And so you may have heard, but there was certainly a tension between the science community, right, and the executive authorities, or the politicians, if you will, who were messaging these recommendations, right? And for example, we saw, recommendations being shelved or downright ignored. And we saw, leadership disinvited from the table in certainly briefings. And so I think Professor Mamo's talk about truth, trustworthiness, and expertise really should be at the forefront of whoever takes the next term in office, but B, also what we demand of our executive, our president, who's in charge of the executive branch. And that is, will they let scientific and public health experts really ask, is there evidence for this? Is this true? And not, am I going to be reprimanded for saying this? Which I think has been the tenor a lot by many public health leaders at the federal level. We've heard from the other speakers about this sort of crisis in communication. And at the federal level, it's been at minimum a crisis. The public messaging and inconsistencies and the messengers have been, from my perspective, embarrassing. And so immediately, whoever takes office should inform the public daily. When the pandemic was thought to be getting better in California, I did fly to visit my parents in New York, and quarantined them for 14 days and pretty much stayed put there. But you saw local officials on TV every day briefing the public. We saw here at the federal level briefings stop for almost a 3-month hiatus, and even those who were giving the briefings were not from the scientific community. Many people will probably recognize the person on the left of my screen as Dr. Anthony Fauci, one of our leading national experts in infectious diseases, but maybe some of you won't recognize who the person on the right is, and he's the director of the Centers for Disease Control, Robert Redfield. And that's because some of these folks were removed, right, from these briefings. And so I would expect and see and ask what we demand again of our leaders in terms of how we inform the public. This part about testing, also another debacle, right? And of course, it's understood that when you're in the first throes of a crisis, a pandemic, you're sort of making do. It's almost like for those of us at teaching, we had to sort of figure out what to do in the meantime before we can plan for this fall semester. Well, the recommendations for testing have also been, inconsistent. And with the health equity idea in mind, we really should be targeted testing, meaning we heard where the most risk and burden is, and that is in communities of color and low-income communities. We saw early on in the crisis that there was no coordination of where to deploy these limited resources. And so sometimes you had people who had means or who were celebrities or athletes getting tested daily. Meanwhile, communities where we know were suffering the most and at risk the most, having limited access to important testing. And from a public health perspective, one of the first things we want to do during an epidemic, let alone a pandemic, is to have a good sample about where the risk is happening and where to then, tailor resources. And so, although, a targeted, by the way, targeted testing should then inform, word and message, contact tracing, et cetera, right? All the different tools we know we need to do to fight a public health crisis such as this. And so the testing program has been, a mess, a debacle. And I know that the Biden-Harris plan that I looked up for this, their plan is definitely much more organized, starting with investments in an infrastructure, building up a public health jobs corps that would let folks be in these communities where we can administer these tests and then invest in the testing labs themselves to turn them around much quicker. And this should be done in as we ramp up our universal testing program. Okay. A few more points. We should be having a federal dashboard with live data. And I know we also heard from our speakers about the importance of data. But early on in the pandemic, it was universities, I think it was Johns Hopkins, who developed the live dashboard that both local health officials and the media used to sort of track the virus. And we're still not at a place where the public can access data in a timely fashion. And that holds back the ability of a robust, coordinated public health response. And so a paper was written by these advocates and organizations who are, at the federal level, urging investments in building an infrastructure that can track this. In that report, it includes better indicators that include things like the number of healthcare workers who have gotten infected, the number of patients who've been isolated with 3 days of symptom onset, the proportion of cases rising even among quarantine contacts. And so we need more granular epidemiology. And right now we have a very piecemeal network of information that I know public health folks are working on, but again, it has been held back by an administration who devalues sort of data and science, and it's just simply not acceptable. Funny how this particular issue of face covering and masks, is a perfect lesson that, and Dr. you covered it well, where we had a crisis in communication. The first and foremost thing we want to emphasize in this response was distance, physical distancing, which we term social distancing. But there absolutely was a back and forth about whether a face covering or mask should be implemented. And we do see growing evidence that it basically works in this way. It, one, protects you from inhaling or having airborne particle viruses into you, but it also protects others around you, right? And so it's the distancing with face coverings, right, that can be effective. And this is a completely perfect situation where we need experts from communities, leaders in communities like faith-based communities, people on the ground who can help talk about the different cultural and different fears, if you will, that came early around with the masks. And so the Biden-Harris campaign has language about a mandate around face coverings. And let me just say that the face coverings are almost like a good duty, right, for each other, right? Because it helps protect you and it helps your family, but also protects those around you. And so in the absence of solid evidence, I think it was almost a perfect case study in how leadership can support the collection of whether or not recommendations like this are effective. And it just took time. Okay, I'm almost done. And I know that this is something that government likes to do, is they like to convene expert panels and groups to help advise. But in this instance, I think it's almost imperative that we just bring in a new panel of responses. And here's what I would urge that panel to do. We need to have a roundtable of experts in public health and medicine and communications that prioritizes scientific understanding, not wishful thinking. And I don't have time to sort of go through the various examples of just the current administration talking about what they think or wish is going to happen, by faith alone. And it was just simply unacceptable. We knew from prior pandemics, the stigma placed upon certain communities that impacts them economically, but also stigmatizes them and reinforces certain stereotypes. But we also know that the recommendations, like to get tested, to wear masks, also have racial and ethnic are affected by ethnic and racial cultural beliefs, right? And so we should know by now what happens to certain communities in an infectious disease outbreak. And we should then have such a response team that is solely dedicated to making sure that the resources are thought about in a way that's fair and equitable, but also considers these recommendations, and they should be institutionalized. We shouldn't have to reconvene such a group every time there's an emergency pandemic. And that such a response team could actually help decide on how to distribute valuable personal protective equipment or a vaccine plan or other limited resources in a crisis like this. We shouldn't be seeing further inequities, racial inequities as a result of a public health crisis. In fact, and then of course, it goes without saying, lastly, we need to be very clear about how businesses, communities, and schools should stage reopenings. And again, it has been a very piecemeal, localized response with very little federal level coordination. And what resulted from that was a lot of confusion and a lot of less trust in those who were there to communicate and make recommendations going forward. And then lastly, at the local level, we actually have seen public health leadership threatened with, public health prides itself, public health officials pride themselves by doing their work behind the scenes. And when we do our work well, you don't even know what's happening. You don't even know we're there. And then it's in the time when we shed the light on a breakdown in response that we do see where we do see the people behind the scenes. And at one point in a matter of, I think it was between April and June, there were about 28 senior public health officials at Lookmore who resigned out of burnout and threats because people simply just didn't want to follow the recommendations put forth. And again, I think this current administration didn't help appease those feelings in the community. And so I would hope that, health is mostly a local practice where the federal government sets forth policies and recommendations and supports it with funding. And I would urge whoever takes office next this fall, take this seriously. And then we learning from other countries. We should continue to partner with scientific leadership in other countries. A pandemic doesn't know borders, yet we saw this administration take the U.S. designees out of the World Health Organization. And I'm not saying the World Health Organization has all the answers, but how are we then to coordinate a response to a crisis that goes across, country borders? And so whoever the next president is, also needs to be that dignitary and be that leader to help us partner better with, our international partners. So my intent was to sort of bring up not an exhaustive list of recommendations, but strong considerations for both you in the audience who are considering who to vote for in the next election, but also lift up some of the recommendations that are needing to be lifted up from our public health community. And in summary, we still need federal leadership. It's imperative to coordinate a robust response, but that should then bring scientific leadership up front, right? And allow and some accountability, of course, but not a crisis where you have scientific leaders worried about what's going to happen to their job if they make a scientific recommendation. I want to say that the SARS-CoV-2, the coronavirus pandemic, isn't a red or blue thing. It's actually a black and brown and communities of color thing. And keep that in mind. Now, of course, I'm not naive to think that there aren't politics involved in health, but I want these guidelines and principles to help guide whoever it is that is in charge of deploying resources and appointing these leaders at our governmental levels. And then lastly, we have been, quote unquote, defunding our public health infrastructure for decades. And so I hope that we have seen how closely tied we are to a strong public health infrastructure that detects and prevents and controls health threats such as this one and others. And so it's a smart investment to me to argue for a strengthened federal and local public health system that we know, it pays for itself, and which we're going to need in the long term.
Thank you very much, David. That was a really interesting presentation about our future as well as the past. I see that we have about 15 questions, and the hour is getting late, but I want to get to those questions. But before I get to those questions, I feel compelled to say a few words myself and maybe exercise the right of the chair to make some comments to the viewers, the enrolled students and members of the public from a political point of view. Normally, I would not be a strong advocate for the political point of view unless I thought it would illuminate some of the comments that were made in the 4 presentations that we heard. And I do want to thank all 4 speakers for their superb presentations. This is a provocative subject. It is, as one of the speakers pointed out, a matter of life and death. And therefore, we need to be as careful, thoughtful, and comprehensive in our thinking. And I want to make 2 points. One that harkens back to last week's presentations on the Electoral College. One of the major messages of the 2 speakers is the split between the responsibility of the federal government and its chief executive and the state governments, going all the way back to the framers in the Constitution and present to this day. No matter what the president thinks, no president can make policy regarding education. It is a wonderful example of the split responsibilities between the federal national government and state and local governments. The federal government only contributes about 10% of the total budget that is spent from K to 12. What happens in education is not a product of what happens in Washington. And we have a constitutional amendment that is very important to remember. And that is what is not left to the president, the national government, remains in the hands of the states and the people. A number of speakers talked about federal responsibility. It may well be that health is not an issue that the president or the federal government, the Congress, can effectively deal with. And this goes to why we have this federal structure. And we heard last week that we have this federal structure because the framers were fearful of a strong national government. The structure of our government is not for efficiency. It is not for someone in Washington to utter a statement and all 51 jurisdictions to follow. I read in the paper yesterday, the Minister of Education in France was deciding whether to open the schools or to close the schools. We do not have a unitary government like France does. The president of France, the Minister of Education, can make statements and make policy that all aspects of the country need to follow. That is not true in this country. And one of the reasons why is because of the supreme value of individual freedom. The framers were more concerned about tyranny than they were in effective government. And for the last 244 years, that DNA is built into our political system. Individual freedom and being anti-state has always been a characteristic of American political beliefs and American political system. The sign that I think Laura held up that said, "My body, my choice," is more American than what David was recommending with regard to central government action with regard to public health threats. Is this a problem during a pandemic? I think it is. Would I want to be in a central government during a pandemic rather than a split government like ours? I think the answer is yes. But we are stuck with the government that we have, and we are stuck with the political beliefs that we have. And when Professor Yu pointed out the differences in nations, I found it revealing that her examples were the Philippines, South Korea, and I think Japan. One of the things we know about Asian society and Asian political systems is they do not have the tradition of individual freedom. They do not, in fact, they have the opposite. They feel comfortable in collective action and in collective decision-making. That's not the American way. If we're going to make the kinds of changes that we need to make with regard to future pandemics, we are going to have to change political values. We are going to have to change political institutions. But as it stands now, the way to respond to this pandemic had to be what some people in the speakers use the word confusion. I might want to use the word diversity. And it was the public who doesn't understand the federal structure that got confused between governors giving different policy recommendations from other governors. That is not confusion. That is the federal system and the diversity between Montana and Alaska and Utah and New York and California. And one size is not going to fit all. And that was always an advantage for the federal structure, that the differences between the states could be recognized in differential policy. I am not challenging the existence of confusion. What I am challenging is whether it was right. We cover the president in the media so much that the average person thinks the president is the government, and we don't cover the governors and the local decision makers, and most Americans don't even know their local decision makers and their state officials and even their governors. And we have low participation for the president elections. We have even much lower participation for state governments. So what I would say is, if I wanted to be critical of the speakers from this point of view, and I don't, I would just say you need to take into consideration the political element and the political values of this society. We are not like a unitary, centralized government. Maybe we need to be. I might argue that we do need to be, certainly during a pandemic, but it's going to require a persuasive effort to make the changes in our thinking, values, and institution to respond according to the requirements of a pandemic. So let me get to the questions, and if we need to stay a little over, I hope the speakers will abide by that, and we'll be able to answer as many questions as we can. Actually, the first question is a methodological question about the recordings, and I should have brought that up. Last week, I didn't know this, but this week I can report happily that we have made arrangements to have the recordings available for members of the public in addition to the enrolled students. And it's a relatively simple link. It really is connect sfsu.edu/the presidential election, all one word. And we hope to have all of the recordings on this link for members of the public to access the recordings. So thank you for that question and reminding me of that important development. The I guess this is for you, Laura. The questioner doesn't understand the relevance of George Floyd with COVID-19.
Sure. And thank you for that, Joel. I think that was really helpful to understand. I have some thoughts about that. In terms of, it may be Arnie's question, Arnie PA, there's a group of questions there, but the connection is really a question about how expertise is used and how to think about the politics of knowledge and to think about the concept of structural gaslighting. The issue, I think, as I already indicated, it is an issue of how we think about what we know, what we don't know, how we trust information, how we can be a participant in knowledge, understanding that knowledge can be political, knowledge can be politicized. So it is an example to bring us to a conceptual argument that I am making that I think is important for thinking about COVID-19 and presidential politics.
Okay, thank you. Let me go. This is a question about the FDA. How can we trust the FDA when they've shown their manipulation by giving emergency use authorization for hydrochloroquine and convalescent plasma on flimsy evidence and without controlled studies? How can we have trust in a public health agency if some of their decisions look untrustworthy? Anyone want to take that?
I'll just say that that's another exhibit, if you will, another piece of evidence how we've had a crisis really of scientific leadership that is certainly laden with some politics. I mean, let's not pretend that doesn't exist. And so I think the larger point, I think, in that question I would answer to is to hold our elected officials accountable in such a way. Like those FDA, I don't look at the FDA as much, but that's a political appointee, as part of the, as part of the cabinet really of the president, right? And so the person we elect at that level gets to choose these people and set this sort of precedent for that. And usually that's not an issue, but it just so happens to be that, particularly in this administration, there has been an obscenity of that overkill of politics into science. I mean, certainly when I worked in the federal government, there were things we couldn't say or touch. We couldn't talk about firearms research, and we had to sort of stress abstinence only, sex, health education for a little bit, right? And so these things are not going to go away by electing a new person per se. But I think it's what you said to Joel about making explicit what it is, the values we hold, right, for the people we elect, right, and sort of demanding that even in the election debates, which we haven't had any really at a time soon, but really demanding sort of these values about transparency and values in science and equity. Like those are really important attributes, I think, in an executive leadership at the presidential level, because they trickle down into those very agencies that make these policies and decisions. And so we have to restore the trust, to be honest. That's the answer to the question is we have a lot of work to do before people can even have that trust again.
Let me try to summarize what I think is a theme in more than one question. You all come from a scientific discipline. What happens when there are differences and conflicts within the scientific discipline? And how does the layperson try to decide between which member of the field they should support? And I'm thinking of a colleague not very far from here at Stanford, who has now been moved into part of the expertise at the White House, who differs very strongly with other members of the expert plan. And how is a layperson to decide which expert they should trust?
Well, I was going to add a little bit to what David said,
Okay.
and maybe I could just try to give some, thought to this. So I think that, to the question of the student or the participant, I think one of the things that you could do, or we all need to do, is to become, as Laura Mamo suggested earlier, to become active and critical consumers of information. And to look at different perspectives from different scientists, and to look at the details of the science. We will have US-based science, but there is science being produced all over the world. And I think that in epidemiology, at least, we know that if we see the same finding with different populations in different time points, then that adds credibility to what we are actually seeing. And so I think that that's one way to think about it.
Okay. Anyone of the remaining speakers want to comment on that, or we can move on?
I'll just add that that's why it's important. I mean, the scientific process usually is a slow one for that reason, right? Because we have to have review of each other's work and checks and balances, and that's the time frame by which we're demanding answers from science is tough, because there's a process for that, and so it's not perfect by any means, and we saw lots of scientific publications being sort of pushed through that peer review process in the past few months because of this demand. And so, in a perfect world, sure, we'd have the time, but I also see how, these things are these politics are at play. So I think the idea I had behind a panel with diverse sets of scientific knowledge and expertise was sort of answering to this point, in this we need to have these various credible experts at the table who are available and supported to do their work.
Okay, let's go to one more question. Let's see if I can get a general question. Someone asked about the address of the recordings, and I didn't give the exact punctuation. It's connect.sfsu.edu/the presidential election. So thank you for that. This question, and maybe this is a good way, is the word blame appropriate regarding a pandemic? The question asked, if the central government has no authority over what is happening in the states, health or education-wise, how can the presidential administration be solely blamed for it? And I would think that maybe the word solely needs to be underlined. If one wanted to be critical here in California, one could say Governor Newsom's advice and recommendations was leading the pack of governors. He closed down facilities earlier than almost any other state, and yet the criticism might be made that we still had a second surge despite the leadership in March and April, and the worst in case studies and in deaths was in July. And so maybe the issue is, and a number of the speakers mentioned this, the politicization of the virus. and trying to lay blame on either one administration or another may not be the best way to go forward. And what we need to do is to recognize that this was a novel event, a novel virus that even the scientists didn't recognize, and that we were learning at the beginning. Part of the anti-mask position was taken by Dr. Fauci himself earlier on, where he didn't think masks were necessary. And then, of course, he changed. Changing does not necessarily mean something pernicious. It means learning is going on. And I think politicians are so fearful of changing positions because they are susceptible to being accused of being manipulated or trying to manipulate the public. We need to respect learning, and learning might be in March, I thought one way, and in April, I thought another. What would the speaker say about that?
I think it's a challenging question. You know, I did this presidential panel 4 years ago. I was invited by Dr. Cacciola. 4 years ago, we had two people running who had not been president. We looked at their platforms and we spoke about it. In this case, we have the evidence of a sitting president. We have 4 years. We have a year of which 6 months or more has been the pandemic. We can see how the federal government and the followers, it's not just the position of the president, but we have a unique situation of a president and his followers. And they are operating in ways that, I mean, somebody wrote the bully pulpit in the comments, but we have also a media that is consolidated, so we don't get local news like we used to get. I mean, the federal power and the power of this particular administration and followers is pretty strong. And we have the evidence. So while this panel might sound a little bit different than in the past, where you just look at two people running, we have evidence. And what scientists do is they look at a lot of evidence and they look to see what we see patterns, what saturates, you know, how are things credible? You see them over and over again. You know, you look at from whose voice and through what processes that knowledge is coming about. And yes, you debate and lots of different positions. And we're in a unique place. It's not just about different positions, but it really is about questioning experts and expertise. Anyway, I'm sorry, I lost track of the question, but I just wanted to say,
Laura, you've made a truly telling point, and I do want to underscore it by drawing the contrast between 2016 and 2020. And I think you used the word that I think as scholars, and certainly my role as a political philosopher, this is one of the sacred words. And I know for scientists, it's also equally sacred. And that is the word evidence. And we need to make decisions on evidence. And we need to look at the evidence as you pointed out. And I think you are really correct in pointing out that Donald Trump is in a different position in 2020 than he was in 2016. And you are correct to point out that we have almost 4 years of policy making, 4 years of making decisions that affect public health and that responded over a 6-month period to the pandemic. So I do think that's a good point to end on. I don't want to keep people beyond what we can do, and that we need to hopefully educate ourselves and use the word evidence and learning and listening to each other and dialoguing with people who disagree with us and analyzing their evidence and have them analyze our evidence. And hopefully that is the way the rational process will produce better outcomes. And I certainly think that that is the goal that can unify everyone, that everyone wants a better outcome. And when we deal with public health, as one of the speakers pointed out, we want less hospitalizations and fewer deaths and fewer cases. And when you have the goal unified, then you can discuss means in a careful, rigorous manner, and I dare say in a rigorous scientific manner. So with that, let me thank everyone who stayed with us beyond our time, and especially I want to thank our panelists, Emma, Laura, Grace, and David, for a fascinating set of presentations about a topic that is happening right now. You all didn't have the benefit of looking back on a past event, but needed to bring order to an event that's literally changing every day. And so I want to express my deepest thanks to all four panelists and for the viewers for staying with us. And next week, we will move to what might seem a placid subject compared to this one, even though in most years it would have been among the most controversial, and that is the economy, which we haven't mentioned here, but one slide, and I forget the speaker, did talk about a balance between public health and maintaining the economy. And this turns out to be perhaps an impossible task. And it might be something we can raise next week with our three economists. So with that, let me invite everyone back for next week and to thank the speakers again. Thanks again. I really appreciate it. Have a good night.